better?
here, so I don't have to.
Has it gotten better?
I feel okay. Just
Oh.
Yes, we do have quorum and can approve minutes. So.
Okay, great.
Oh,
Okay, today is Wednesday, November 12th, 2025. This is the Medicaid Oversight and Advisory Board meeting. DJ, could you please call the roll?
Senator Berg, Senator Carroll,
Here.
Senator Meredith,
Present.
Senator Richardson, Representative Heverin, Representative Marzian, Representative Mosier, Representative Williams, Vicky Yates Glisson, Holly Harris, Joe Petrie, Steve Shannon, Senator Douglas,
Present.
Senator McDaniel, Representative Bowling, Representative Petrie, Beth Bowling,
Here.
Laura Sudkamp, John Hicks, Lisa Lee, Sheila Schuster,
Here.
Stephen Stack, Tom Stevens, Co-Chair Fleming, Chair Adams.
Here. Okay, looks as if we have a quorum and we are constituted to do business. First order of business, do I have a motion to approve the October 22nd, 2025 minutes?
Motion to approve.
I have a motion. Do I have a second? I have a second. All those in favor signify by saying aye.
Aye.
Any opposed? All right, the minutes are approved. It looks like we do not have a jam-packed agenda today, so I do not anticipate this meeting to too long. So let's go ahead and get started. Our first agenda item is the update on the Rural Health Transformation Fund. Dr. Stack, please make your way to the table. And Dr. Langeveld, if you all could please introduce yourself for the record and proceed with your testimony. Thank you.
Good morning, Madam Chair. So I'm Stephen Stack, Secretary of the Cabinet for Health and Family Services.
Good morning.
And please introduce yourself.
Yep. Good morning. My name is John Langfeld. I'm the Commissioner for the Department for Public Health.
Okay, and per protocol, we are going to swear you all in for the record. And so will you please raise your right hand? And do you swear or affirm to tell the truth, the whole truth, and nothing but the truth?
I do.
I do.
All right, thank you very much. Please proceed.
You know how to get rid of that?
Yeah. Let's switch display settings.
There we go. No. There we go. Wonderful. Well, good morning. So, Madam Chair, normally we would try to fit this in 10 minutes, but if you're okay, we'll just take a little longer. That way we're not quite as rushed. So thank you for the opportunity to be here today. We have submitted our application for the Rural Health Transformation Grant that was submitted on November 3rd, and I'll come back to that at the end of the slide deck. So I'm going to do a summary part about the overall structure, and Dr. Langfeld's going to go into the actual stuff I think you want to hear that's the newest thing, which is what are the initiatives we're going to target and what are we going to try to accomplish with this money should we get funded. So I would think of this grant at this point in time as a $50 billion, $10 billion a year. So it's $50 billion over 5 years, $10 billion per year grant. The mechanics of how they get to what our final award matter to us, but I don't think it really matters to the state in certain ways, because once you get approved, the way that CMS is going to administer this, it's going to vary significantly, I think, across the states what they get funded or don't get funded. So think of it this way. Our goal is to get approved, and then after that, CMS will determine how much money we get. The rest of the mechanics don't almost matter for this purpose here. There are some unique elements to this grant. I've shared some of this verbally before. Now you have it here in writing in a slide deck. They're going to use scoring for part of the application. Some of those scores are going to have to do with how they assessed the proposals we gave them, and their perception of our likelihood of success and the structure and the way we did it. Other things are going to have to do with, use this non-English word, rurality, how rural our state is. There's certain ways they've defined those metrics. Those are not things we can change. They're going to be, here's the way we did it, and here's what the result is. And then there's some elements that have to do with public policy and health policy. I'm going to come back to that, but you had to make commitments and commit that you would deliver those proposed changes by the end of 2027. So essentially 13 months from now, or 13 and a half months from now. I'm going to come back to that on the next slide. The states have got to demonstrate progress against their milestones each year, and CMS is going to rescore you each year, which means this grant will change in economic value year over year, which makes it somewhat hard to plan. If you knew that we were going to get a fixed amount grant for each year for 5 years, you could sign contracts and budget and plan accordingly. You could see states perhaps vary tens of millions of dollars year over year, depending on how CMS grades you at the end of each performance year. So that adds another layer of complexity. Additionally, in H.R. 1, the bill that created this, they specifically said that CMS determinations were not subject to appeal, that they were, CMS had the unilateral determination, and that the states did not have appeal rights. That's also unique. Usually there's an opportunity for appeal if there's a difference of opinion. And they do say that we will work with a project officer beginning soon and for the life of the grant to oversee this. That's pretty typical for a federal grant. So we were required to attend to at least 3 of these 5 strategic goals on the left. So make rural America healthy again, sustainable access, rural development, workforce development, innovations in care, and technology innovations. And we had to attend to those. We had to do at least 3 of the things on the right side. And so you see there were prevention and chronic disease, provider payments, consumer tech solutions, training and technical assistance, workforce development, IT advances, appropriate care availability, behavioral health, and innovative care. Now, again, this next slide, I think it's the next slide, I'm going to talk about some qualifications on some of this. There are limitations in this. Some of these are typical limitations in federal grants. Others are unique to this grant. One, you're not allowed to supplant existing funding. So we can't take this money and pay for things we're already paying for with state dollars. That's pretty typical. That's routine. We are not allowed to build new buildings. We're allowed to use a modest amount of money, there's limits, a percentage of the total award, to help subrecipients or partners maybe modify or renovate lightly some of their internal spaces or spaces they already have, but we cannot build new buildings with this money. We're also not allowed, in that telecommunications thing at the bottom, we're not allowed to pay for the installation of monthly broadband internet costs. Of course, Kentucky has a number of areas still that do have trouble with broadband access, which is essential for telehealth, but we cannot pay to help Kentuckians get broadband internet access using this money. There are other limitations, and so on the top right there you'll see no more than 5% of the money can be used towards an electronic medical record. So this was intended to allow only a very modest amount of money that could perhaps support enhancing people's adoptions of electronic medical records. And we also, and this is a big limitation on one of those 9 things on the previous slide, they have been very clear. There's things that are in writing, but then when you meet with them in person, the leadership over this CMS initiative, they are very clear. They have no intention of this money paying for clinical services, certainly not filling in for loss of revenue that's going to be lost by rural hospitals or other providers simply because of other aspects of H.R. 1. So what you have to do is innovate care. You have to design new models, new ways to deliver care, new ways to promote and provide rural access to rural health care. So they're very, very clear about that when they present this verbally. And that's important because if you were just to look at that previous slide and look at the list, you see provider payments there. They have very substantially qualified and limited that in every presentation that I've attended and that Dr. Langfeld did at as well. So here's the timeline we told you. So remember, this became law on July 4th, And by December 31st, per statute, they're required to tell states if they're getting an award, and if so, how much. Just to put this in context, CMS took 44% of the total time just to write the homework assignment. And then they took 32% of the time at the end to grade it. And they very generously gave the states 24% of the time, or a total of 6 weeks, to reconceive all of rural health care in their entire state. So it was a tough assignment, but that kind of puts in context just how tough this is. We got ahead of it a little bit and requested on July 29th, stakeholders to submit to us any written comments, and we've provided all of those comments to the committee at its request. So you have access to what we had access to. August 31st was the deadline for people to submit stakeholder input, but I will qualify. We had around, oh, that's inconvenient.
Attention, may I have your attention, please? A fire emergency has been reported in the building. Evacuate the building immediately. Use your assigned exit route or alternate safe exit. Use the stairway. Do not use elevators.
Oh, my goodness.
Requiring assistance, follow the established evacuation protocol.
Okay.
Okay, this really is not a planned one, so I guess we have to GO. We stand at ease.